Sometimes patients will go into surgery for various reasons, various symptoms that are not necessarily clear as to what's causing them. And at the time of surgery, they're actually found to have cancer. And I think that that's likely what happened in this case.
In January, I underwent major abdominal surgery in London, and at the time, it was thought that my condition was non-cancerous. The surgery was successful. However, tests after the operation found cancer had been present.
It is quite common that patients will present with non-specific symptoms, perhaps abdominal pain. Commonly, patients will complain of maybe blood in their stool or bleeding, cramping sometimes. And that generally will lead to further diagnostic workup, CT scans and things like that, in which case you might find abnormalities that are not necessarily clearly indicative of cancer, and that could lead to a surgery. And then once they undergo the surgery, then it becomes more clear what was the cause, either it being a benign instance or similar to this case, a cancerous cause.
My medical team therefore advised that I should undergo a course of preventative chemotherapy, and I'm now in the early stages of that treatment.
We generally expect at least 4, sometimes up to 12 weeks of recovery after the surgery before we would consider starting chemotherapy. There are obviously patient level factors. If a patient has a side effect from the surgery, develops an infection or something like that, then that would probably delay our initiation of chemotherapy. When people talk about preventative chemo, really what we're talking about is when a surgeon goes in and removes all the cancer that they can see. And sometimes that's all the cancer, and sometimes that's just all the cancer that they can see. And there are tiny cells that are floating around that are still cancerous. If we were to do surgery alone in those patients that still have those tiny cells, the cancer will almost certainly return. And so when we talk about preventative chemotherapy, the goal of the chemotherapy in that setting is to kill off those remaining few viable cells that are sort of floating around, that haven't had a chance to sort of take up shop yet and really set up their roots. The reason why we might consider adjuvant chemotherapy is actually based on the risk of that patient, that individual patient, developing recurrence of the cancer. The risk of recurrence is calculated by a number of different ways. We look at the tissue or the tumor that's been removed under a microscope, and we will look to see how involved it is in the primary mass. Has it spread to lymph nodes that are surrounding it? Has it spread to other organs surrounding it? And that gives us sort of a stage, which most people have heard of, stage 1 through stage 4. Based on that staging, that gives us a pretty good statistical idea about what is the risk of this patient developing recurrence. We use that information and decide who is the best candidate for chemotherapy, for preventative or what we call adjuvant chemotherapy in this setting. A cancer arising within the abdomen is a very non-specific term. We would generally zone that down to an ovarian cancer, a colon cancer, a small intestine cancer, a stomach cancer, a liver cancer, a pancreas cancer. So although those all sort of arise generally within the abdomen, they are distinctly different cancers and are treated, generally speaking, quite differently. There are any number of different chemotherapies that are used to treat different types of cancers. So one of the regimens is a combination of an IV that generally is given about once every 3 weeks, and then pills that are given twice a day. That's a very common regimen that is given for colon cancer, but it would not be the same kind of regimen that would be given if you had ovarian cancer, endometrial cancer, or other potential types of cancer. And so really, when we're talking about chemotherapy in general, that's sort of an umbrella approach that really doesn't describe what one patient would get versus another. It's impossible to say what would be the best treatment because the best treatment is different for individual patients. With that being said, the IV and the oral chemotherapies are very similar in terms of benefit or efficacy. And so I don't think that there's really a profound benefit one over the other. In terms of kind of the road ahead, when a patient undergoes surgery and then followed by chemotherapy, there's some recovery that takes place there, right? I think it makes sense when you think about somebody going to surgery and they remove, part of the bowel or, part of the body, that has to heal. And so, there's some recovery that goes for that. And then on top of that, we're giving chemotherapy after that. And so that sort of blunts or can slow that recovery. That's not to mention that, chemotherapies do cause side effects, right? The side effects of chemotherapy can range from the worst of the worst, where you have, nausea all the time and vomiting and lose all your hair. And then there's on the other end of the spectrum where you have almost no side effects. The chemotherapies that, I use in my practice are sort of in the middle, where they are, tolerable, but they certainly cause side effects. Most commonly, most all patients will have some level of fatigue, weakness. Generally, we would not expect patients to be so fatigued that they're bedbound, but definitely feel weak and tired. Certainly nausea, vomiting can happen. Fortunately, we have great drug medications to sort of help reduce those risks of nausea, vomiting. Depending on, again, on the types of chemotherapies, they can decrease the blood counts and increase the risk of patients getting infections. Sometimes people will get side effects like numbness and tingling in their hands and feet, what we call neuropathy. So there's a whole host of potential side effects. Fortunately, most patients won't get all of them, but unfortunately, almost all patients will get some of them. With that being said, in a young, otherwise healthy person, my expectation is that, they will be feeling, my hope and my expectation is that they will be feeling, back to their self within 3 to 6 months of completing chemotherapy. Now, when I say back to yourself, I don't mean exactly back to how you were before you had a cancer diagnosis, but back to sort of being able to, participate fully in, daily activities, and hopefully sort of on the road to full, recovery. When you think about kind of ultimately our goal is that the cancer is gone forever. And so we're doing everything we possibly can to get that patient to cure. And then once we finish with that, that 3 months or 6 months, however long we'd be giving the chemotherapy, then it becomes more of a surveillance. Let's get back to focusing on, feeling better, recovering, and all the while we're going to be monitoring to make sure that we do not see any clear evidence of the cancer recurring. It's a slow journey to recovery, getting, and it depends on the type of symptoms. My hope would be that, in a relatively young and otherwise healthy patient, they would be able to recover, sooner than that. And again, it's a slow process, and it's not like, one day you wake up and you're recovered. So when we talk about going to surveillance, we generally will follow patients for 3 to 5 years to make sure, with generally CT scans and other imaging modalities, because we want to make sure that if they have evidence of recurrence, we find that. Of the people who will recur, which hopefully will be a small proportion in this case, the vast majority of those people will recur within the first 3 to 5 years. And so that's why we follow with CT scans and things like that over the first 5 years, depending on the disease that we're talking about.